afternoon, and welcome to the 2023 CMS Quality Conference. I'm Anita Montero, the Director of the Quality Improvement and Innovation Group here at CMS, and I'm especially delighted to welcome you all to this distinguished panel of leaders to discuss a revival of the patient safety movement. I can't think of a better panel that has earned the right to speak authoritatively on this critical quality and safety issue than four of the founding members of Patients for Patient Safety US. We're looking forward to a great session ahead. Today, our panelists will share practical solutions for safer care that have their genesis in the stories of patients and their family members. Our objectives today are to better understand the scope of harm suffered by those who experience preventable patient safety events, learn about the contributions of patients and families to designing patient safety solutions, and be offered the opportunity to partner with patients, family members, and others urgently working to achieve objectives that advance patient safety and health equity as interconnected goals. It is my pleasure today to introduce four of the founding members of Patients for Patient Safety US. I'll begin with Carol Hemmelgarn from Denver, Colorado. Carol was driven to the field of patient safety after she lost her 9-year-old daughter, Alyssa, to multiple medical errors. She's passionate about transparency and communication, especially after medical errors, the power of storytelling in healthcare, and the aftermath endured by providers, patients, and families when medical harm transpires. Carol has a master's degree in patient safety leadership from the University of Illinois at Chicago and a second master's degree in healthcare ethics from Creighton University. She's worked in healthcare for over 30 years. Currently, she's the Senior Director of Education for the MedStar Institute for Quality and Safety. She is also the Director of the Executive Master's Program for Clinical Quality, Safety, and Leadership at Georgetown University. Welcome, Carol. Thank you for being with us today. Our next panelist is Armando Nahum from Atlanta, Georgia. In 2006, Armando and his wife, Victoria, began their work in patient advocacy by establishing the Safe Care campaign after 3 family members experienced healthcare-associated infections in 3 different hospitals in 3 different states in 10 months' time, culminating with the death of their son, Josh. Armando has been a driving force in establishing patient and family advisory councils for quality and safety at each of the 10 MedStar Health System hospitals and in Vizient member hospitals across the country. By engaging patients and families and educating them about sepsis, Armando was part of a MedStar team that included Dr. Meena Seshamni, now Director of the CMS Center for Medicare, among other dedicated providers and patient safety advocates. Their work reduced sepsis mortality by 35% at MedStar and has become a national model recognized with multiple awards. In February of 2020, Armando was appointed to the Presidential Advisory Council for Combating Antibiotic-Resistant Bacteria. On November 14, 2022, Armando was invited by the HHS Secretary Becerra to open the session at the National Healthcare System Action Alliance. An amazing and impressive body of work. Welcome, Armando. Thank you for being with us today. Our third panelist, Sujin, is a board-certified geriatric pharmacist in Illinois and Wisconsin. She pursued this career after losing her dad, a Korean immigrant, to many gaps in healthcare due to communication barriers. She specializes in medication therapy management and believes empathy can make healing possible in any relationship of healthcare. She's experienced in both inpatient and outpatient pharmacies and has worked as a population health pharmacist that manages complex medical regimens and helps with social determinants of healthcare. She's also a certified professional in patient safety and a certified professional in healthcare quality. She is an ambassador for the Patient Safety Movement Foundation, a nonprofit organization dedicated to achieving zero harm in healthcare, where she passionately speaks up about patient safety, patient rights, minority health, and patient advocacy for voiceless patients. She speaks English and Korean and is eager to help patients. Tremendous background and dedication. Welcome, Sujin. Thank you for being here with us today. Our final panelist is Steve Burrows, a comedic storyteller, a writer, director, and performer who's entertaining audiences for 25 years. In 2009, in a 180-degree career turn, Steve dropped out of show business to take care of his mother, Judy Burrows, a retired Wisconsin public school teacher who went into a coma and experienced permanent brain damage during a routine partial hip replacement. Confronted with the failure of Judy's providers to take responsibility for the harm caused by substandard care, and faced with daunting healthcare expenses that drained his family's financial resources, Steve embarked on a 10-year fight for his mom's life and for medical and legal justice. This journey became the award-winning, critically acclaimed HBO documentary film, Bleed Out. Steve, his wife Margot, and the entire Burrows family hope that Bleed Out, which was seen by millions, will serve as a call to action for systemic reform in American healthcare, as well as legal system, and are happy to see that hospital systems and medical, nursing, and law schools have now made it a part of their teaching curriculum. In honor of Judy, the Patient Safety Movement Foundation created an annual award for excellence in patient safety, named the Judy Burrows Humanitarian Award. Steve was its first recipient in 2020. Previous Patient Safety Movement Foundation humanitarian award winners include President Barack Obama and then Vice President, now President Joe Biden. While deeply personal, real-life tragic events have brought this panel into this work and in collaboration with each other, I'd like to start off by extending them our deepest condolences on their individual personal losses. Your stories are heart-wrenching. I'm sorry you've had to experience these losses, but I would like to applaud you for your grit, your resilience, and admirable dedication to this cause, so the rest of us do not have to go through the experiences you went through. So thank you for being here with us today. It is now my pleasure to turn the session over to you, Carol.
My name is Carol Himmelgarn. I am a founding member of Patients for Patient Safety US. I run the Executive Master's Program at Georgetown University and the Educational Program for MedStar Health Institution for Quality and Safety. But first and foremost, I am a mom and I am an activist. In February of 2007, my 9-year-old daughter, Alyssa, was diagnosed with leukemia. This was a Monday afternoon. 10 days later, Alyssa died. However, in this day and age of healthcare, you do not die of leukemia in 10 days. She died of multiple medical errors. What led to her unsafe care? Well, first, there was a label put in her medical record, and it was biased, and they anchored on this label. She was in an organization that was very hierarchical, and it was a culture that lacked psychological safety for residents, physicians, nurses to go up the chain of command and feel like they could speak up. She was a classic case of failure to rescue. She got a hospital-acquired infection. So what were the results of all these? Well, the anchoring bias led the care team to be locked in that diagnosis and could not see that she was failing. They ran 2 lab results that when they came back showed that they were critical lab results, and no one acted upon them. She was septic. But they did not listen to me, her mom, the person who knew her the best, when I kept telling them something is wrong, something isn't right. She suffered a horrific and painful death. The first harm to Alyssa was unintentional, but it was the multiple harms afterwards that were intentional. When we were lied to, when we were threatened, when we weren't able to talk to the care team who cared for her, when my signature was forged to get an autopsy. when parts of her medical record were hidden till the statute of limitations passed. And the fact that it is 16 years later, and I still do not know exactly what happened to my daughter. Alyssa's death has changed how I live in the world. It's lonelier and it's isolating. I am part of an exclusive society that no one wants to be part of, and that is the loss of a child. I have strained family relationships, but probably the one that is the most difficult is watching the intergenerational harm it has caused Alyssa's brother and my son. But what if there was transparency? What if there was a communication and resolution program in this organization? What if they'd have captured my story, since I was the only one there 24/7, and I was able to contribute to the event review and cause analysis and make it more robust? What if those learnings didn't take 3 years, 7 months, and 28 days to come out, and they were shared across not just that organization, but across the country? But what if the first intentional harm was the only harm and not all the other intentional harms? What if? Sujin?
Thank you, Carol. Before I begin, I'd like to thank CMS for this opportunity to share my dad's story. My dad was a foreigner, a businessman. His name was Gain Lee. He was a quiet, voracious reader, and he loved advocating for justice. He was diagnosed with stage 3 esophageal cancer when he came to the United States, which was 16 years ago. And at the time, I was a wedding videographer. I was the sole caregiver. And it was devastating news to find out, especially because he was a foreigner. That meant there would be an access issues. And he was a foreign language speaker, so there was language and cultural barriers that we had to think about when we were accessing care. Because it was hard for him to swallow food and drink water, he had to be hospitalized for a G2 placement. And after that, he had to be transferred to a nursing home. Then he had to come home when we ran out of money to afford nursing home care. There were about 20 different medications. And this was the most frustrating task that I had to do, because on top of that, he had to be tested 5 times for a regimen called sliding scale insulin. So on top of his cancer, he was diagnosed with type 2 diabetes in some time in between the transitions, which I did not know until he came home. And sliding scale insulin regimen is difficult for caregivers. What that means is you would test glucose for the patient, and I would inject the insulin according to the result. So the higher reading, I would give higher dose. And because his cancer was in the esophagus, because of that, he had difficulty swallowing even water, and he was often dehydrated. And glucometer could give false reading if patients are dehydrated. And I would give higher dose insulin because it gave higher reading, and he would crash because now his glucose is too low. We would rush to ER. They would restore the glucose and discharge him without education and what we could do to prevent if something like that happened next time. 2 weeks later, the same thing happened at the same hospital, same discharge. And we were lost. And I was lost. I was following doctor's order religiously. I trusted healthcare because I did not know anything better. Because I felt I lacked the knowledge I needed to care for my father, and I thought I was in good hands. At hindsight, it was the biggest mistake and something that I still carry with me as a burden and a guilt. We were devastated, and we sought care in South Korea. And with that decision, we had to go to South Korea, and we booked our flight for all of us, including my kids. And 1 week before, I would get a call from my father when I was out to shop for groceries. And he said, "Please come now." And he had severe abdominal pain. We had to go to ER again. This was the third time. And he passed away 1 week before our flight. The reason why I'm telling you this story is, what if there was a class we could go to after the discharge to learn about medications? What if there was an advocate we could consult with because we had language, cultural, and access barrier? What if there was a shared decision-making session that we could choose what medication he could be on? And what if healthcare was designed around empathy and compassion, where we can train clinicians and people who work in healthcare to learn about these skills? What if?
Thank you, Sujin. Armando?
Thank you, Carol, and good afternoon, everyone. As mentioned earlier, my name is Armando Nahum. I live in Atlanta, Georgia. I am a patient safety advocate and a founding member of Patients for Patient Safety US. Because of my advocacy, I wear many different hats every day, from advisory boards to infection prevention councils across the country, and yet none of them compare to the happiness of just being Josh's dad. My story goes back to 2006, when 3 members of my family were impacted with hospital-associated infections in 3 different hospitals, in 3 different states, culminating with the death of my son, Josh. He was 27. A whole number of harm events occurred during Josh's 6 weeks in ICU. 2 separate cases of MRSA, delirium, and finally a gram-negative bacterium in his cerebral spinal fluid, and then finally sepsis, shutting down all of his organs. Poor hospital cleanliness and no hand hygiene compliance were definitely instrumental in his infections. His death certificate stated that Josh died from an accident he sustained prior to being taken to the emergency department. And yet, an investigation from the news agency Reuters discovered it to be false. Not a single event was ever communicated to me or my family, and certainly there were no mechanism in place to even report all that transpired during his hospital stay. 1 year later, my wife and I visited the hospital to see what was put in place that would maybe help prevent similar harm event, only to find the same poor cleanliness and no signs of hand hygiene compliance. Since then, the largest healthcare system in the Mid-Atlantic, MedStar Health, asked me to help them with a system-wide sepsis initiative, certainly not from a clinical point, but rather from the patient perspective. And so I would like to play a video for you that attributed to that successful initiative.
You know, I live with two words, if only, every day. And they play a big role in my life, because if only I had been more educated, if only I knew about sepsis, maybe my son would be alive today. Josh was very fit, he was healthy, he had done over 1,000 jumps and he had become an instructor, so he was very healthy. On Labor Day weekend of 2006, Josh was on his last jump, and there was a cold air density problem that pushed his chute inward and threw him to the ground at 60 miles an hour. Josh was jackknifed. He broke his left femur, and his helmet produced a contusion in the back of his head. He was immediately taken to the emergency department, and upon arrival, his brain started to swell. Josh acquired not one, but 2 cases of MRSA. He battled and won those, and then he acquired what they call delirium or ICU psychosis. But he won it. He was strong, and he fought all of it. And then finally, the doctors came to us one day after 6 weeks in ICU, and they said, "Mom and Dad, it's time to go home. Josh is doing well." 6 days into rehab, we received what we called the phone call from hell, 11:30 at night, from his neurosurgeon, saying that at rehab, Josh spiked a fever of 103, and he coded. Go to the emergency department. It's the only place that they're equipped to handle sepsis. Learn the symptoms. Even if you think you have the flu, if you have an infection, you're running a fever, you have any of the symptoms, say the words, "I suspect sepsis. I think this might be sepsis." If the person suggests that it might be sepsis, that means they need to be seen right away. Sepsis is extremely treatable, but you have to catch it early. Call 911 immediately. Do not waste 1 single minute. And when you get there, say the words, "I suspect sepsis."
As the video states, the if only and the what if are words that play on my mind every single day. What if I knew about hospital-associated infections and hand hygiene protocol? What if I knew about sepsis? What if hospitals engage patients and families in their care? What if hospitals behave with the highest level of transparency, like MedStar Health you've seen in that video? And what if I knew the words to say, "I suspect sepsis"? Thank you.
Thank you, Armando. Steve?
My name is Steve Burrows, and it's an absolute honor to be with you all today. 14 years ago, in 2009, in Milwaukee, Wisconsin, my retired school teacher mom, Judy Burrows, went in for a routine partial hip replacement and came out in a coma with permanent brain damage. Here are the basic facts of what happened back then. After walking on a failed hip surgery for 5 months, my mom fell again. She lay in the hospital in excruciating pain for 8 full days with no plan of care. I was living in Los Angeles, so I got on a plane from LA. I call her surgeon, who was a family friend, and he immediately rushes mom into hip surgery while still on 3 blood thinners, where she proceeds to lose over half the blood in her body in 45 minutes. She's taken up to the ICU, where her blood pressures repeatedly drop to deadly levels. And it turns out the bedside ICU doctors in this hospital system were replaced by an eICU, an electronic ICU camera doctor. But we were told that camera was never on due to patient privacy. The eICU ICU setup didn't even notice my mom was in a coma for 2 full days and had suffered irreversible brain damage. I was the one that found her in a coma. What do I know? Nothing. Then my uncle, who's a doctor, and my aunt, who's a nurse, they dropped the bomb on me. They looked at the handwritten anesthesia records for my mom's hip surgery and immediately tell me they had been falsified. My uncle, the doctor, tells me there's a cover-up and then I need to become power of attorney. I need to get the medical records before the hospital changes them anymore. And then I need to get a medical malpractice attorney. We're going to sue. My head's spinning. I don't even know what I'm doing. Now, I quickly find out that getting a medical malpractice attorney is an extremely difficult thing to do. Attorneys only take the very best cases in these kinds of things. And even then, attorneys for injured patients across America lose 90% of these cases. Now, despite all odds in our case, a Wisconsin super lawyer takes our case saying there's overwhelming medical negligence. Medically, my mom would never recover, all due to loss of oxygen to her brain. Her IQ dropped from 120 to 60. She now had the cognitive abilities of an 8-year-old. She was ruled incompetent. Physically, her legs don't work. Her bladder dies. She loses control of all of her bodily functions. She's got this spontaneous regurgitation and a never-ending parade of deeply unpleasant collateral damages. And she also lost her ability to speak. Financially, my mom went broke. Her 50-year life savings, which she was incredibly proud of, was gone in less than 3 years, all paying for all the injuries I just told you about. Her perfect credit was obliterated. So now mom is on Medicaid because she needs 24/7 care, which is now being paid for by all the American taxpayers instead of those responsible. And on top of that, my mother repeatedly threatened to kill herself if she can't go home. She wanted to go home, and she said she would kill herself if she didn't get there. So the only way we can ever afford to bring mom home is to win our lawsuit. Now, the hospital, their attorneys, and the insurance companies in our case would go on to successfully delay my mom's day in court for 7+ years. Now, one of the things we found out during those 7 years of litigation, besides the fact that my mom's surgical anesthesia records were indeed medically impossible and had been falsified, was that this eICU system that didn't notice my mom was in a coma for 2 days had also replaced bedside doctors at 18 other ICUs in this system, meaning that one camera doctor was watching 160 other critical care patients like my mother with cameras that weren't on. But when my mom's surgeon, who was a family friend, started spilling his guts to me in private while saying the exact opposite thing under oath in court, that's when I decided I would go undercover. And that's when I decided to make a documentary, our HBO film, Bleed Out. 3 years ago today, after 10 years of relentless pain and suffering, my mother would die from those horrific injuries, but not before she'd become a cottage industry for over 150 doctors, 7 hospitals, 50+ healthcare providers, 10 law firms. My mother, Judy Burroughs, and her injuries became a big business, earning folks millions of dollars. And these are the what ifs that I constantly ask. What if provider organizations took financial responsibility when their own internal investigations found breaches in the standard of care, as opposed to shifting the cost to Medicare and Medicaid? What if the court system was not the only option for patients and families like us to find out what happened to their loved ones when something bad occurs? What if there were financial incentives for truth-telling and/or penalties for cover-up if they were in place? Would the concept of let right be done trump delay, defend, and deny in healthcare? What if it was required of hospitals to use the eICU system as it was originally intended, as a safety net backup system and not as a replacement for actual hands-on bedside ICU doctors? And what if hospitals were held to the same standard of integrity Medicare and Medicaid has for its beneficiaries to take care of the people they serve, Now, it occurred to me in preparing for this singular opportunity to speak with all of you today that through our 10-year siege fighting for my mother, so many people cut out on our family. We lost friends, family, doctors, healthcare providers, time, money, trust. But the record shows we never lost Medicare or Medicaid. You folks never cut out. You were always there for my mother and our family. I recently got to thank President Joe Biden for that, and I sincerely thank you all as well. Thank you.
Thank you, Steve, Sujin, Carol, and Armando for sharing your stories and your what-if possibilities. I want to ask you a couple of questions, follow-up questions, to better understand some of the what-if possibilities. So Carol, if I can start with you, what are the key features of a communication and resolution program, and where do you see this working well?
Thank you, Anita. I know right now that we're looking at creating a structural measure that would include communication resolution programs. And really what they are, it's a structured method to communicate with patients and families after harm. It starts from the reporting, the importance of reporting, how you're there to care for the care providers, care for the patient, be honest, truthful, and transparent about what happened, and then not abandon everyone after the harm. That it is part of the care process, that after harm transpires, it's not just send them out the door and goodbye, it's taking care of everyone. So it's truly a program that's embedded in systems, and the outcome is to maintain that provider, patient, family, trust, and communication.
Thank you, Carol. Sujin, you talked about the lack of discharge instructions and the lack of training or information on medication management and medication effects. So in your opinion, what can providers do after discharge to educate patients and their families about medication effects?
I could be biased because I'm a pharmacist, but I believe pharmacists are most underutilized professional in healthcare that can prevent readmissions and harms for patients. And this gap of educating caregivers and patients can simply be filled with pharmacists' time and the placement of where they are. So discharge processes and transitions of care and follow-up after primary care doctor's visit even. There are so many opportunities that pharmacists are able to do these things, but they're not providers under Medicare federally. So that's a barrier that many pharmacists have in terms of being able to use their skills to prevent harm for patients and caregivers.
Thank you, Sujin. One of the themes, I think, of all of your stories and what-if scenarios is this underlying foundational need for empathy and compassion. So I want to ask you, either Sujin or Carol, can training really increase empathy and compassion? And how can providers implement training that achieves these goals?
Go ahead, Sujin.
So there are studies out there that have shown these are trainable skills. And there are companies out there backed by researchers. One that I can think of is Harvard professor Helen Riss has studied in residents and students who have used her methodologies to train these people, and it showed the increase of the measurements that she measures, and they are biological and the measurable increase in empathy skills. So, and there are other researchers in the world who are studying this methodology, and it has shown the promises that it's a doable. So,
thank you, Sujin. Was there anything you wanted to add, Carol?
Anita, I think part of it is intrinsic as to who we are as well. We know there has been a lot that's gone on since COVID, and we know the stress and strain on the healthcare system and providers. But I think if we always flip the lens of what if this was your family member or your friend, that empathy and compassion can be there if we just look at it through a different perspective.
Thank you, Carol. Well said. I want to switch gears a little bit here. And Armando, just amazing work with the 35% sepsis reduction across MedStar hospitals. So I want to dig into that a little bit. What role did you play in co-creating the sepsis initiative at MedStar? And more importantly, what role did the patient and family advisory councils play?
Yes, thank you, Anita. It's an interesting question and requires quite a bit of time, but I'll try to condense it for you. When the Vice President of Quality and Safety came to me one day and asked me to participate in the sepsis initiative, the system-wide sepsis initiative, I immediately went to the bathroom because I felt like I was fainting, that they would ask me to do such kind of work, and I'm not even clinically trained. But the idea was that they needed a set of eyes from the patient perspective, right? Not from the clinical team. And so I started at the very first meeting, I actually sat there and sort of kind of learned what was going on. And after about 1 hour, I watched these 10 different hospitals arguing which protocol to use. And so I finally raised my hand and I said, you know, from a patient, you actually expect me to know which hospital to go to that performs best. It just doesn't make sense. And being that you're the same company, you should all follow the same protocol. And the conversation stopped. And they said, he's right. You know, we should adopt one protocol. The next question I asked is, show me what is the wait time in your ED? Because my understanding is, and they taught me a lot, and the understanding was that 80% of sepsis comes from the community, while 20% only occur in the hospital. So if 80% come from the community and they come through the ER, what is your wait time in the ER? And when I found out that it's usually around 3 hours, I said, it's impossible. You're already in septic shock. So you should reduce wait time to 0. And they looked at me and they said, we can't. And I said, yes, you can. Just take the vitals upon entry, and immediately, if it's connected to the EMR, the electronic health record, they'll fire sepsis. And it could be a false positive, but better safe than sorry. And so they did that, and it showed improvement almost instantly. But my biggest thing was that I found out, and this still goes on today, most healthcare organizations don't invest in patient education. There's no ROI in that, right? But if you have a patient and family advisory council, those are the people that are doing the legwork for you, because they can go back in their community and being associated with their churches, synagogues, temples, senior centers, they can spread the word for you. And that's exactly what we did. So that idea just went, like wildfire, because MedStar having each hospital has a PFAC, a Patient Family Advisory Council for Quality and Safety. They will go out in the community and spread the word. And so all of a sudden we had all these people that had almost overnight learned about sepsis, and it was incredible. And I think that helped in the overall reduction that you mentioned at 35%. Not to mention that, obviously, kudos to the clinical team for doing all the work. So my involvement was really minute in terms of the improvement overall in MedStar Health for sepsis. But I want to share a quick story that because of that model, out of the blue, almost weekly, I would get a call from systems across the country and say, oh my goodness, we heard about the sepsis initiative and you were a part of it. So we're reaching out. How do we find an Armando? And I started laughing, because it's like, you're giving me more credit than I deserve. I'm nobody. I said, but if you really want to know, you have lots of Armandos in your hospitals. And they said, Where? And I said, you know what? Why don't you look at your grievance database and go back 1 to 2 years? And I'm sure somebody lost someone to sepsis, and bring them in for a conversation. If they live in your community, they would want your hospital to be the best it can be. And the answer was, we're not ready for that. Because in order to do that, and this is where I give kudos to MedStar Health, it requires full transparency. And I was able to sit here in my own office at home and be able to look at their, go through their system. They gave me the right to look at each hospital, how they performed in sepsis. That dashboard was mind-blowing to me, because that truly requires transparency. So if hospitals start thinking in that directions, everyone can improve.
Thank you, Armando. And I know you've played a very significant role in that initiative. You're very modest, but thank you for sharing that the model can be replicated, and it can be just as effective, if folks have the will to make that happen. So I want to switch gears a little bit here. And Steve, you've shared such an incredibly, powerful story of the circumstances around your mother's death and your fight, afterwards to right, in some ways at least, what was wrong. I've watched the documentary and it is incredibly powerful. I'm curious as to how the healthcare community in America has reacted to Bleed Out.
Well, thank you, Anita, for watching the film and for that question. When the film came out, I was nervous about the healthcare reaction, the healthcare community. I was confident that we might do well with the press and the public, and I certainly with the patients out there in the world, but I wasn't so sure about the healthcare community, because as you saw, it's a very hard look at a personal story that expands out to the universal. But I was very wrong on that. Universities, medical schools, nursing schools, healthcare organizations across the country and now the world have now embraced our film and my mom's story as part of their teaching curriculum. And we've just found that when we screen it, like the Q&As afterwards, they last longer than the film itself. For whatever reason, I think because, I shot this thing on my iPhone over a period of 10 years. It's very first person. It's in the moment. And I for some reason, it just has initiated unexpectedly. I had no idea this was going to happen, but there have been these profound discussions on how to make healthcare better and safer for all of us with these young clinicians. As you know, we're all patients. And I feel like maybe when these young medical students and nursing students see our film, they get that. They get that it's not only just, it's not us versus them. We're all like in this together. And just last week we had a screening, and I had a Mayo Clinic doctor tell me that my mom's story will forever change the way he practices medicine. And I can't tell you how much, something like that means to me and our family. The medical schools have repeatedly told us after these screenings that they really believe that my mom's story is just forcing a dialogue that is helping save lives down the road. And honestly, it doesn't get any better than that. My mom was a school teacher. Now she's out there all these years later, still teaching. This is my mother's legacy, is our story. So thank you.
Thank you. Thank you, Steve. And yes, it's hard to walk away from either the film or any one of your stories. It's hard to walk away unchanged. I think it humanizes quality and safety and the initiatives around it. So thank you so much, Carol, Armando, Sujin, and Steve, for your dedication, your continued work, and more specifically, your partnership with CMS. I have great relationships with you and our team has worked together really well on these initiatives that you care so much about. So thank you for working with us as we make healthcare in the United States safe for all the people.
So now we ask of all of you, what would you change at your workplace, at your organization, payment, healthcare structures? Our question of you is, what is your what if? Thank you.